slightly different from what has been presented prior. Here I'm going to speak more on the perspectives of intervention nephrology in South and Southeast Asia. South and Southeast Asia is the home to around 1/4 of the world population. The population is diverse, and the practices and the economy is also diverse. So the aim of the study was to mainly understand the practice, trends, needs and resources of the intervention nephrology in the South and Southeast Asia. So what we did was we circulated a questionnaire which was drafted to presidents of 16 societies of nephrology in South and Southeast Asia. After they filled up the questionnaire, a follow-up discussion and a face-to-face meeting was performed during the last Avatar conference. The countries were divided into two groups. Based on the World Bank data, economies are divided into four groups: high, upper middle, lower middle, and lower. So high and upper middle were classified as Group 1 countries, and lower middle and lower were classified as Group 2 countries. The values are expressed as percentages, and the result section is unplanned dialysis initiation was seen in 70% of the patients in Group 2 countries versus 43% in Group 1 countries. In Group 1 countries, Singapore and Malaysia had higher unplanned initiation versus Nepal and Bangladesh in Group 2 countries had a lower unplanned initiation compared to other countries in their groups. Vascular access in the incident hemodialysis group, non-tunneled catheter was the most common vascular access in the incident dialysis group in the Group 2 countries compared to tunneled catheters in the Group 1 countries. Singapore and Malaysia in Group 1 countries are exception, where they go for a non-tunneled catheter in the majority of the incident patients, which is then converted to a tunneled catheter and subsequently an AV fistula. AV fistula as a vascular access in the incident patients is seen in 1/3 of the patients in the Group 2 countries versus 40 to 60% in the Group 1 countries. Singapore and Malaysia are lower in the Group 1 countries, and also the Hong Kong is slightly lower compared to Thailand because of the first use of PD policy as a compulsory in Hong Kong. AV fistula in prevent hemodialysis patients. 3/4 of the patients in all the countries were on AV fistula for their regular hemodialysis. Pakistan and Hong Kong are an exception. Only 18% of the dialysis patients were on an AV fistula. The reason for this is because of the cultural and the deniability of the disease in the population. Hong Kong is because of the PD first policy. What are the procedures which are being done by intervention nephrologist? 60% of the nephrologists in the Group 1 countries and 90% of the nephrologists in the Group 2 countries perform interventions. The interventions are 93% of them do a kidney biopsy, 80% of them do a PD catheter placement, 2/3 of them do a tunneled catheter insertion, and 100% of them do a non-tunneled catheter insertion. What are the constraints for intervention nephrology? Time constraints seen is reported in 3/4 of the people. Lack of formal training is also reported in 3/4. The fear of medico-legal is seen in 50%. Interest in glomerular nephritis or transplantation is seen in about 50%. Lack of backup support is in 40%, and lack of resources in 1/3 of them. And point of care ultrasound is available in all the countries, and fluoroscopy available to the unit is only seen 50% of the units. Formal training in intervention nephrology. This is the country-wise percentage. 87% of the countries, people who do intervention nephrology undergo a formal training for performing a biopsy, similar with non-tunneled catheter insertion, and 60% for tunneled catheter insertion, and 60% for PD catheter insertion. Vascular access screening is done by nephrologists in 40% of the countries. In 1/3 of the countries, it's more of unit-specific, and in 1/3, it's by none. They don't do any vascular access screening. And who does the vascular access screening? In 20%, it's by the dialysis technician. In about 60%, it is by the nurse. And in 2/3, it's by dialysis doctors. Yes, there are countries in which the vascular access screening is done by multiple, the doctor and the nurse, both of them do the vascular access screening. That is why you have more than 100%, yeah. Preferred modality of vascular access screening is the clinical examination followed by the KTYB assessment and urea reduction ratio. The cost of an AV fistula and a tunneled catheter is very variable even in the affordable Group 1 countries. It ranges from $42 in Taiwan to $1,400 in Singapore for an uninsured patient. Similarly, $50 for an AV fistula in Sri Lanka to $1,500 in Singapore for an uninsured patient. So the last slide, a summary of the findings, is one of the first comprehensive study of the status of intervention nephrology in South and Southeast Asia. So about 2/3 of the nephrologists do perform intervention procedures. Kidney biopsy, non-tunneled catheters, and PD catheter insertions are the common intervention nephrology procedures. The first vascular access is mostly a tunneled or a non-tunneled catheter depending on the country. And AVF is the most common and seen in 3/4 of the prevalent hemodialysis population. The lack of training, backer support, and economic constraints are the barriers for intervention nephrology in the region. Thank you.